Uh, Good afternoon, everyone. On behalf of the Tobacco Control Section at the Union, SIPHER and ECHO India, I, Dr. Paridhi Mody, warmly welcome all of our distinguished speakers, colleagues, participants for joining us today on this online international consultation on smokeless tobacco use, health problems, and socio-economic issues in Southeast Asian countries. Smokeless tobacco remains one of the most under-addressed public health challenges in our region. While smoking often dominates policy discussions, smokeless tobacco continues to contribute significantly to oral cancers, cardiovascular diseases, and socio-economic inequities across Southeast Asia. Today's consultation brings together expertise from policy, public health, legal frameworks, and international experience. The goal is to strengthen the regional narrative and response around smokeless tobacco control. It is my honor to invite our chairperson for today's session. We are honored to have with us Dr. Rakesh Gupta, who is the chairperson of the TC section at the Union. He also serves as the President and Director of Public Health at Strategic Institute for Public Health Education and Research. Sir, I welcome you to please give your welcome address.
Yeah, thank you, Paridhi. So next, please. So we are holding this online consultation on smokeless tobacco use, health problems, and socio-economic issues in the Southeast Asian countries, as SLT use is highly prevalent in Southeast Asia due to deep-rooted our cultural acceptance, high accessibility, low cost, and widespread misconceptions about its safety compared to smoking. And some people, they even tout it as a harm reduction strategy. So over 90% of the global SLT users, they live in this region, driven by traditional use of product like paan and gutka. I welcome Dr. Jagdish Kaur, Regional Advisor, uh, the Tobacco Free Initiative, who will be shortly joining. So Dr. Shalini Singh, Director NICPR, Dr. Lakshmi C. Ramatunga, she's a former Additional Secretary Public Health Services, Ministry of Health, and now she's a consultant with the Vital Strategies. Mr. Ranjit Singh, who is an Supreme Court advocate, a legal consultant, and Ms. Supinder Kaur, who is from TC section, the Union, and Dr. Paridhi from ECHO India. And all the eminent participants, I welcome you all very warmly. And let us listen to Dr. Lakshmi, what she has to say. Dr. Lakshmi, next, please.
Thank you, sir, for giving the welcome address. It is my pleasure to invite Dr. Lakshmi C. Tomatunga, who is the former Additional Secretary Public Health Services at Ministry of Health in Sri Lanka and now serves as a consultant for Vital Strategies. Ma'am, I invite you for your talk on broader health and socio-economic implications of smokeless tobacco use. Ma'am, should I share your
Thank
slides
you.
or? Uh,
Yeah, please display it from your
yes,
end.
yes.
Yeah. Thank you very much for this great opportunity because I happen to be a national focal point on tobacco control since 2000 in my country for many years until I go to policy level. Still, even after that, tobacco control was my purview as it's a major public health problem. So use of SLT, smokeless tobacco, presents a unique challenge for public health, not at country level, locally, regionally, and globally. So it's a big challenge. Next slide, please. I'm starting with the overall situation. I thought the overview will be given by somebody else anyway. Good that I'm talking first. The overall situation, if you say across the world, smokeless tobacco is used by more than 300 million people. So this results, please keep that
Yes,
slide.
yes, sir.
Yeah.
Just give me a second. I think I.
Yeah, that's okay. First one and go to the 30 to 60. Yeah, that's right. And the use of smokeless tobacco is responsible for loss of around 6 million disability adjusted life years. So that is alarming. And it is prevalent in all the countries, only all the continents, all the continents. A considerable proportion of this burden comes from our own region, the Southeast Asia. Why I say in all the continents, it's at least in 140 countries they use smokeless tobacco. And though it is more in Asia, the second is Africa, then South America, and it has penetrated to even in Europe now. In at least 29 countries, 10% or more of the population uses smokeless tobacco. So it's a global problem. Next slide, please. When you talk about the burden, out of 1.3 billion tobacco users in the world, and at least a quarter, because 356 million use tobacco, that means 25% of whole tobacco use in the form of smokeless tobacco products. And it is a major, often under-regulated public health menace, and also under research as well. In South and Southeast Asia, smokeless tobacco products are not only cheap, it is easily accessible, but also socially acceptable and considered part of the cultural heritage. That is why the global efforts to control smokeless tobacco are lagging behind the progress made in curbing cigarette consumption. I have my own experience. We could do a lot for cigarettes, but not for smokeless tobacco, as expected, because of this situation. Socially and culturally, it has been accepted for a long years. Next slide. And there are so many misconceptions and safety concerns as well. Smokeless tobacco is not a safe alternative, but people think it's safe comparatively because no smoke. So, and it contains the same harmful chemicals. Most of the chemicals are there. And no level of use is safe. Next slide. We'll go to the impact on health. Previous one. Yeah. I want to talk about health inequity, disease burden, and high health expenditure under this impact on health. Disproportionate rates of cancer and cardiovascular diseases in users from lower educational and income backgrounds, creating a big inequity. And when you take the disease burden, this is responsible for significant global mortality and morbidity due to many people know that oral cancers are attributed to SLT, but esophageal, laryngeal, pancreatic, stomach cancers, and also cardiovascular diseases. So severe impact on national cancer incidence as well, because in the world, it is one of the leading causes for deaths. And high health expenditure also. Talk about treatment for illnesses caused by tobacco accounts for a significant portion of healthcare spending, often overwhelming low-income families. And just think about that the countries who provide healthcare for free, the burden they have to take on controlling not only treatment, diagnosis, treatment, and palliation. Because diagnosis of these non-communicable diseases, cancer is a major non-communicable disease, cardiovascular disease is a major non-communicable disease, and their Screening is also high cost. Tests are high of high cost, and sometimes very big queues in order to get your appointment also. So time resource wise is really high burden to countries. Next slide. Socio-economic impact. We have a disproportionate impact here because smokeless tobacco use is higher among lower socioeconomic group and in rural areas and specifically targeted population. This reinforcing social inequalities. I say especially this targeted populations mean I give from my country the experience. Now look at the country level, our tobacco use is somewhat okay compared to other countries in the region. But when you go to the pockets like estate population, slum area, this is much higher than the national level. So that is why in some populations, it is much, much more. It diverts the household income from basic needs, deepening poverty, while high usage rates among disadvantaged groups perpetuate health and economic inequalities. Next slide. Economic burden. Yeah, on households. Money spent on smokeless tobacco reduces household income. We know about that. Available for food, healthcare, and education, leading to higher poverty rates. This is a serious thing for children because for them, food, health, and education are the most important things. And I want to cite quote here from some research studies. In 2007, in a study done among the beneficiaries of a poverty alleviation program, we came across that 45 to 50% of their monthly income spent on tobacco and alcohol, both. That is why they are poor. And also in my own study published in Indian Journal of Cancer in 2012, it was revealed that 19 to 20% of the income of low socioeconomic group in rural community spent that 19 to 20% of their income spent solely on betel quid. It's 1/5 of their household income is spent on SLT. And the same income category in the same study, it was revealed that in urban areas, they spend 6% of their income for only for betel quid. So rural and urban, 20% of their income versus 6% of their income. So there's a disparity there. And exposure to and usage of smokeless tobacco by youth and women is high, often driven by peer pressure and easy access, which can negatively impact long-term health and education outcomes. You know, in women, when they use it, and children observe it, children see it from their childhood. So invariably, if when the mother does something, they invariably adapt that. So this is why it is so difficult to control. Next slide, please. Productivity losses. So smokeless tobacco-related diseases such as cancer and cardiovascular issues cause absenteeism. So it is missing from work. And presenteeism also, when they present, they work with reduced capability, leading to lost income. I give an example. in estate communities where this smokeless tobacco use is very much higher than the national level. They need to reach a target, how many buckets of tea leaves they pluck. When it is reduced, their daily wage is reduced proportionately. So this is so serious. They work with diseases and they are already in low socio-economic group and further decrease in their income. So that is why the impact, socio-economic. When economic impact is there, it is automatically goes to social problems. Right. Then next slide, please. So social development impairment. The high prevalence of smokeless tobacco, for instance, hampers overall economic development by reducing the quality of life and productivity of the workforce, as I explained with earlier slide. Next slide, please. I want to talk about on global development, the impact of use of SLT on global development. At the beginning, I told it is not a national problem, it's not a regional problem, it's a global problem. Because the topic of the era, you can say that sustainable development goals. It has implications for global development, particularly in meeting these SDG goals. We are now at 2026, only 4 more years to reach 2030. So out of these 17 goals, there is a direct relationship with SLT and these 9 sustainable development goals. There are other goals as well, which has an indirect impact. But when you take first one, no poverty. So it is there. So zero hunger, because which otherwise gone for food, no, they spent on SLT. And good health and well-being, obviously. Quality education. How can children get quality education when they use it and when they are poor? The essential needs are not available and gender equality is not there. And clean water and sanitation is affected. As I said earlier, decent work and economic growth. So it is affected. And reduce inequalities. How can we reduce these inequalities if you cannot control this very, very high key risk factor for non-communicable diseases, tobacco, and particularly smokeless tobacco, which is not under control. And life on land, the 15th goal is for sustainable environmental. And you know that for curing of tobacco leaf, you need a lot of trees. So they are responsible for deforestation and also decaying of soil with the tobacco cultivation. So how can you achieve sustainable environment? So all these 9 are directly related to smokeless tobacco use. So as these are world's goals set by the whole world, so it has a direct impact on global development. So that is why I'm so happy that we talk about this and let this be a good advocacy for many researchers and many policymakers to take control over this. Next slide. I think I have, yes. Why it is important to control this smokeless tobacco. It is crucial for global health to bridge the policy gap. We are going along with the Framework Convention on Tobacco Control. We have done a lot at our individual country levels and also as a region. Especially, I want to mention Southeast Asia region. Our voice was really important at the global platform. So we have done a lot to smoking, but we have not done enough. We were not being able to do for this smokeless tobacco because of the reasons I described earlier. So under research, not under control. So then it is very important that we prevent the initiation. So it really, most of the time, it starts from the home. And strict regulations are needed. High taxes are needed. We must be innovative to convince the religious leaders, community leaders, and to reach the unreached in order to make the population SLT free. And correcting the misconceptions are really important. So we need more focused public education and targeting the specific risks, especially during pregnancy, in order to overcome nausea. This end of world, women go for SLT. So wrong attitude and act, and other children and other people see it and they adapt it. So these are the important things. We should go for that. And I want to say that again, to emphasize that it's the socio-economic impact, the negative socio-economic impact caused by smokeless tobacco is not a country level problem, not a regional, but it's a global problem. I think the last slide is the next one. So I want to say thank you, and I hope many will undertake research and many policymakers will go for innovative ways of controlling this SLT. We are very happy to share our own experience with others. Thank you very much.
So thank you, Dr. Lakshmi. And you told about the overall situation of the SLT, that is 25% it is being used globally as part of the tobacco. The input on the health, the socio-economic impact, and how the productivity losses are there. And the last slide actually says it all, what you want to say. There's a bridge between to bridge the policy gap. It is under researched, and preventing the initiation. Strict regulations and taxes are required. Correcting the misconceptions, that more focused public education is required. Targeting the specific risks that is used during pregnancy. So we'll just summarize them and send to the policy makers also. So thanks a lot. Thank you, Dr. Lakshmi. So now we'll call Dr. Miss Upinder Kaur, who will tell us about the overview of why this consultation is being held. Yeah. Yes, Miss Upinder. She's part of the team of the Tobacco Control Section, the Union.
Good afternoon, everyone. Sorry, there's some technical issue with my phone and my camera is not working. So we've had a very intense discussion about what is the burden of smokeless tobacco and how it is affecting not just the health but also the economic burden of it because of the premature deaths that happen around the globe. And we all know that. So I just have a brief presentation, but though many points of it would be a repetition of what ma'am just spoke about, but I'll just quickly go through it. So in today's consultation, our main focus is to put our priority of tobacco control onto the smokeless tobacco also, because we all know that SLT use in our country is at the highest if we talk about the global scene. So, just a general of what smokeless tobacco is. We all know that the common forms of smokeless tobacco that are available there in the market. One is the chewing tobacco form, in which you talk about the gutkas, the khanis, and the chewable loose leaves and everything that is there. The traditional chewing tobacco that has been available in the market. The next is the snuff or the dips, which is which is something which is placed under the lip, and we are seeing that there's a huge growth of the third product, which is the snus, in which there's no spitting allowed, because till now in our country we've been trying to control SLT through the spitting bans, but with the introduction of snus, and we are seeing that how this product is basically actually generating a lot of attraction in the youth and an early initiation of tobacco use. And also the dissolvable tobacco strips, which we haven't seen much in our country, but it is for sure going to reach to our markets too very soon. Can we go to the next slide? We already heard about the burden of smokeless tobacco. We know that it does affect every part of our body. Cancer being the foremost important disease that is caused due to chewing tobacco. Then we have heard that how chewing tobacco increases the risk of cardiovascular diseases, and the most affected area in use of tobacco use is your oral cavity. So oral and dental mobility has been the major leading effect of use of tobacco use. Can we go to the next slide? So if we talk about the burden of smokeless tobacco, we all know that because it is an easily available tobacco product, and also well, the pricing of which is very cheap. So usually the initiation starts at a very young age. And we all who are working in tobacco control are aware that, if the tobacco use is initiated at a young age, the long-term use and dependence becomes even more stronger. Then their maternal and child health effects. We have also seen that chewing tobacco is very common among women because of the social taboo related with the smoking forms of tobacco. So the chewing tobacco becomes one element that women fall onto, and that actually affects in a lot of maternal and child health effects that happens. And economic and social burden we've already heard in the previous presentation, so I will not go in much detail of it. Can we go to the next slide? So this is a slide which is very important and which highlights why today's consultation is so important, and how the country's priority now really needs to shift on the smokeless tobacco only. That we know that worldwide we have 300 million smokeless tobacco users, and out of those approximately 200 are just in our country. So which is a huge number. And also, as per the GATS 2, if we see the prevalence of smokeless tobacco use, it is around 21.38%, which is higher in men, 29% in men, and 12.8% for women. And even if we break down on the forms of smokeless tobaccos, it is majorly kheni and gutka, but we are seeing that the new products of smokeless tobacco, which are actually entering the market and getting a lot of popularity among the youth and tobacco users. Next. I think again we have already spoken about it, and we know that significantly the prevalence of smokeless tobacco use is more in the rural areas as compared to the urban areas, and also the users start between as early as 18 years or even younger than that. So we have the major chunk of smokeless tobacco use initiations between the age of 18 and 34. And it is very well known that the health impact of smokeless tobacco is throughout our body. So I think just not going further more into the slides, the major aim of today's consultation, and I congratulate the TC section and Cypher for organizing such an important webinar today. Why SLT is so important? Because we know that 90% of all oral cancers are directly related to the use of tobacco use. So it becomes very important to have more focused policies in this area, in which we can completely ban the use of smokeless tobacco, and whatever different demographical differences that are there in the country, we need to adopt those policies individually. So over to you, sir, for taking this webinar forward.
So you're muted. Dr. Rakesh, sir, you are muted.
Yeah. So thank you, Upinder, for being very precise about the overview of the SLT problem in Southeast Asian countries. So, Paridhi, I may suggest that you may take a snapshots of all those who are present. So, Dr. Jagdish Kaur is with us, and Dr. Shalini is with us, and Mr. Ranjit is also with us. So, they are the speakers. And I must also acknowledge the presence of Dr. Rana, Dr. Siddhi, Dr. Dilip, Susan, Mr. Casey Sani, and Dr. Shirko Omar from Iraq. Yeah, thank you. Can we have a snapshot of all?
Sure, sir. Yeah, we can do that first. So I would request everyone to please switch on your videos, and we can have a group photograph to commemorate the consultation. Okay, so on the count of three, bright smiles, everyone. 1, 2, 3. I will just take one more. 1, 2, 3. All right, thank you.
Yeah.
So, thank you, Ms. Upendra, for giving a very clearly outlining the objectives and the context for today's consultation. It is my pleasure and honor to invite Dr. Shalini Singh, Director, NICPR, who will deliver the keynote address on countering the economic narrative of the tobacco industry, an example from Africa. She has more than 3 decades of working in this area of research, and I welcome ma'am for her presentation.
So, thank you, Dr. Rakesh Gupta. Can you hear me?
Yeah, sure.
Yes, ma'am.
Okay. So, thank you for organizing this webinar on an important topic related to health and socioeconomic issues from the use of smokeless tobacco in Southeast Asia. And Dr. Lakshmi from Sri Lanka highlighted, what are the health and socioeconomic impact of smokeless tobacco use in the region. While I was searching for interesting articles which can also, add to what all research has been done and how people are using different methods and different arguments to counter the industry's narrative that it is not a very lucrative option, and that it generates revenue, and what will happen to the livelihood of farmers who are the tobacco growers. So all this has to be constantly countered with data and with research. So I came across this nice study from Africa, Mozambique, and where, that they have, I'll explain what the study says, and similar examples I think we need from our region as well. So while we all know that, tobacco growing is recognized as a barrier to global health protection strategies, and it's mostly driven by the harms of tobacco consumption on the one hand, and also the environmental degradation caused by its production. So specifically, the Article 17 of WHO FCTC requires that the parties who are signatory to this, the treaty, they work towards reducing the supply of tobacco and also promote viable alternatives for the livelihoods of those farmers and all of those stakeholders who are involved in the tobacco industry, beginning from the tobacco farmers, the growers, the sellers, all of them, so that they can address the socio-economic impacts of tobacco control in a very positive manner. And also that since the tobacco industry has historically sort of leveraged tobacco growing to oppose the tobacco control measures, And they always suggest that if there is no tobacco farming, what will happen to the rural communities, especially the small farmers. And the government does not have much evidence to counter this narrative. So this example from Mozambique was, this was a study they have published where they have included more than 1,300 households in who are, and Mozambique has, they have taken two the tobacco producing regions, two tobacco producing regions in that study. They surveyed it in 2021 and then again in 2022. And they have actually brought to the fore that they've examined the tobacco cultivation through the lens of commercial determinants of health. So which brings together what are the issues of the tobacco industry and those of the health which overlap each other, so that it gives a better understanding how tobacco farmers get into this vicious cycle and they're not able to come out of this tobacco growing. So in this study, what they found was that they took 4 groups. One group A was the persistent growers. That means that these farmers cultivated tobacco both in the year 2021 and in the year 2022. And then in another group, group B, they were the persistent non-growers, which means that they did not grow tobacco in either of the years 2021 or 2022. The third group was the new growers who did not cultivate in 2021 but started the tobacco cultivation in 2022. And group D was those farmers who exited tobacco cultivation in 2022. So that means that they grew it in 2021 and they exited in 2022. So now they have seen what is the socio-economic profiles of these households, and they had significantly varying trajectories. So it was seen that the age of the farmers who exited the sector, which means that they were no longer growers, were a little older. That means around 45 years of age, while the newer growers were significantly younger. They were around 38, 39 years of age. So 5-6 years of age difference was there. Then another very interesting finding was that in the gender, that while most of the households were headed by males, it was seen that the non-grower group, the group B, they had a higher proportion of female-headed households, 7.9% or same 8%, while those who were persistent growers, both in 21 and 22, 98% of them were headed by males. So here's where Dr. Lakshmi was also mentioning that, women are affected more, so possibly they take action also in favor of their health once they are told and they are educated. Now, they also saw the education levels. And while they were generally low across all the 4 groups, the newer growers exhibited that, their formal education was least among them. So with 41% haven't ever gone to school. While amongst the persistent growers, 38% had completed less than 5 years of schooling, which means just barely primary educated. So highlighting, that education also plays a very important part. And that is why if governments have to take action in moving the farmers away from tobacco growing, education will play a major role. Apart from that, then they had studied land and assets that they had. So what they found was that the persistent growers had a significantly larger total land areas as compared to those who exited or those who never grew. Also that the type of labor that they employed, so agricultural casual labor was more used, that in their strategy. So those who were like casual labor, 63% of them were used for tobacco growers, whereas in the new growers, they engaged about 48% of labor, casual labor. They also studied the supply chains, and so how the companies contract, their representatives contact these farmers, and how the company collectors or they aggregate the small farmers towards a cycle of borrowing and debt. So that was also seen. And they also found that, the net income, because mostly what happens is when we calculate what are the revenue benefits, we forget the health and other benefits. So what this study showed that the non-growers and the no longer growers, they earned significantly more from other cash crops. That was vegetables and cotton and so on, soya bean and so on and so forth, than those households who continued to grow tobacco, either in the first year and second year both, or at least in 1 year. So the true economic weight of tobacco is visible once we take into account all the other areas also. So this is what I think we should capture in our future studies, and especially in the Southeast Asia region. And they also found that the persistent growers, they faced highest deductions from the tobacco companies, because tobacco growing is also very labor intensive. So if though people were more educated, that was taken into account. So saying that those who were had higher education, if they were gainfully employed in other education, what amount of income they would generate as compared to the minimal wage which is given to the tobacco farmers. So all that was taken into account, and then they found that those who cultivated tobacco in 2020 but did not grow it later, they were sort of better, they had a better opportunity of coming out from that tobacco cycle of growing and regrowing. So overall, what we can say that education is very important for if we have to bring out these farmers out of tobacco growing. And they also, in their study, they've also suggested some proof of concepts, which are, I think, will be very important when we do similar studies in our region. And this will help in policy and programming. So I thought just to give a different flavor to the webinar, we thought we'll this study was just published in February this year. So I thought I'll just mention about this. So that's all from my side, Dr. Rakesh.
Yeah, Dr. Shalini, thanks a lot. And I may just request you to please share the link of the study in the chat box. So
I'll do that.
the study was countering the economic narratives of tobacco industry, and examples from Mozambique you presented. And you told us that how that the farmers who cultivated till 2022, they found better opportunities by stopping growing tobacco. So that is an interesting study. So please share the link. Thanks a lot.
I'll do that.
Thank you, ma'am, for sharing the points from the research done in Mozambique. It's a very interesting read, and we are looking forward to the link. Regulation remains a critical pillar in tobacco control, and to help us understand the legal framework governing smokeless tobacco products in India, I will invite Mr. Ranjit Singh, who serves as an advocate in the Supreme Court and is also an expert on anti-tobacco laws. So over to you.
Thank you. Thank you, Dr. Rakesh, for bringing this topic up. I think smokeless tobacco, as I agree with the previous speakers, is something which is by and large neglected by the policymakers, and we are focused more towards smoking despite being a huge prevalence. Can you share the first slide? You want?
Yes, sir. Just give me a second.
In So even in the region itself, by and large, we are under the framework of, FCTC, and therefore, there also the focus has largely been on regulation of smoking kind of products. And smokeless has somewhere been kind of ignored. And here, uh, I'm though I'll be citing more kind of incidents from India and the best practice that have gone into regulating this product there. But it is something that we need to collectively work towards there, because there are enough rules, regulation, and frame which are not kind of implemented properly. Next. So I think the previous speakers have spoken a lot on the different kind of smokeless tobacco product. I would only highlight from the point of regulation. It was a challenge because from each region, states in the India, the habit kind of change and the product change. So in some states where something more was prevalent, it's not necessarily they were prevalent in other states also. So just from the way of use, I'll say there are a range of chewing tobacco kind of products where you chew it, which could be, the gutka, flavored chewing tobacco, etc. Then there was a whole range of product which was kind of, taken like a, uh, under the lip, something like sucked, which you have the cool lip, etc. by the product. And we've had cases on cool lip, specifically on use of children on that aspect. Then you have the dental application like gudaku, which you put it on the teeth and then they use it. And then you have nasal kind of use also, which is your snuff, snus, etc. So what I'm trying to project here is that with each state, region, the use of SLT changes, and therefore the regulation becomes very challenging, because for each kind of different kind of product, you would need to apply different law, and that's for we'll look into that next. So I think the SLT facts mostly related to burden, and it's already been the prevalence in GATS has already been notified. I think almost 80% of our tobacco use in India is in the form of chewing tobacco, and therefore we need to look into it more seriously. Then there are obviously the health impact are there. The recent the parliamentary committee highlighted that 50% of oral cancer is linked to smokeless tobacco use. Economic burden was already highlighted. I won't go into it. But there are other facts I would like to say, that like gutka and kani are the most commonly used in India. They are marketed as mouth freshener. Manufacturing cost is low. That's why with each state and region you see change in in brands and etc. Because you can just start manufacturing in a small room with a machine where you throw in tobacco dust and flavors and chew and betel nut and make it product. So the brand keeps on changing, and that's what we see change. The other thing I wanted to highlight also, that chewing tobacco has been a food product. And there are doubts in people's mind, but I want to make it very clear that in 1954 we had the first law, which is right kind of, during the independence we had the first law which came out, which was the Prevention of Food Adulteration Act. In that act, proper licensing was given to gutka and chewing tobacco manufacture. In fact, you had health warning under the PFA law. So there is no doubt that chewing tobacco or gutka, etc., were regulated as food products since the time of independence. There. Next. So what changed? What changed was basically a lot of, I'm not going to the background, but in 1980s, when these products which were innovated and something which was in a very available in a coarse kind of a zarda and tobacco form was now packaged with flavors, etc., and became very prevalent. So then you had a lot of studies, scientific study, which explained about the ill effect. At the same time, you had state coming with bans, etc., on these products. And then in 2006, you had a law called the Food Safety and Standard Act. Now, this act specifically talked about laying standard of food and providing safety and safe and and wholesome food. Now, in this act, which is a kind of a which was a follow up to the PFA Act, which repealed the Prevention and Food Adulteration Act, the chewing tobacco and gutka was not fitting in, because the mandate of the act changed from stopping adulteration of food to providing safe and wholesome food. So there are certain sections which is basically giving duties of to food authority, to food business operator, which said that you will provide safe and wholesome food. And then you have a section 30, which is very widely used by state government, which gives an emergency kind of power to the Commissioner of Food Safety to prohibit anything in the any food article in the interest of public health. So this needs to be clear that something which was treated as food under a separate law, which was repealed by the new law, uh, because the mandate of the law has changed. And therefore, I'll go into the specific regulation which dealt with these products. Next. So these are certain regulations. The first regulation is of Food Safety and Food Additive Regulation of 2011, which lays down standards for pan masala. So the pan masala product you see, which is available in the market and which is advertised, there is a specific, guidelines and standards for it, that what a pan masala will contain, which becomes important because anything beyond these guidelines is then violation of the law and amounts to adulteration. And therefore, a lot of states who have used this provision to highlight that some product had magnesium carbonate and some other product which was not part of the standards and therefore violation, and they've acted it into. This next important regulation which is widely cited is food prohibition and restriction on sales regulation, which has a clause called 2.3.4, which clause specifically says that tobacco and nicotine shall not be used as ingredient in any food product. Now, a lot of states have used this clause and banned gutka, which is betel nut mixed with tobacco, etc., and also pan masala with tobacco and nicotine. Though they mean the same thing, but they are kind of used interchangeably in state notification. But this was the clause that has been used very widely, called clause 2.3.4, which prohibits the use of tobacco and nicotine as ingredient in any food product. The next is packaging and labeling. So you specifically have a labeling requirement for any advertisement and any package of pan masala, where you will have to mention chewing of pan masala, and this even extends to supari also, is injurious to health. Now, what has changed in 1.5 years is that this warning has to appear in the 50% of the front of packet of pan masala. So that's been a development recently into 2024, when the Delhi High Court passed a judgment. So now every pan masala has to show a warning which covers 50% of the front of package, saying it's injurious to health. So these are certain regulations. And lastly, as I mentioned, that there are regulations which bans the use of anti-caking agents, magnesium carbonate. I'll specifically explain why magnesium carbonate is used for pan masala. Next. So, like I said, regulation 2.3.4 is the prohibits the use of tobacco and nicotine as ingredient in any food products, and therefore gutka and pan masala as a product, if it contains tobacco and nicotine, is banned. This is the only product where all state governments, all union territory have issued separate orders where they have banned these products, citing this regulation. And presently, this matter is sub judice before the Supreme Court of India. You have judgment in 2013 and 16 where they are monitoring the compliance. You have letters from the Ministry of Health and Food Safety to states requesting for strict compliance of the ban on gutka and pan masala. Next. So this is the Supreme Court judgment of 2016. This, I think, last para clearly asked state governments to file affidavit saying that they have need to file compliance affidavit for enforcing the ban. Next. So how does the industry react to the ban? So industry starts manufacturing the same gutka, like you see earlier. You see the pan parag packet which has one called gutka, but now the same pan parag comes in two sachet. So one sachet has got pan masala, the other has got chewing tobacco. Now, so then we were taking it as surrogate, and we were started taking action against the chewing tobacco packet. But then over the years they have adapted and they've changed that also. Now you have the pan masala, which is heavily advertised, available with another chewing tobacco product which has no brand name as such, popular brand name, and they can be bought from every shop. Now, these are some states I've highlighted, which includes, Mizoram, Manipur, etc., Punjab also, Haryana also, where they have issued orders on banning all forms of smokeless. So that was one way of dealing with this menace of twin packet sale. And there also they use the clause 2.3.4 regulation and section 30, which is the emergency power of the Supreme Court, which is Commissioner of Food Safety Commissioner. But this power is limited to 1 year, and therefore after every year they have to change the regulation. But this is one way to deal with the twin packet sale. Next. Then there were specific orders from state. This is two examples, one from Bihar and one is from Madhya Pradesh. But there were several state government which used the Supreme Court judgment and said that twin packet sale is whether sold in single packet or separately is a ban. Therefore, gutka should not be sold there. So they passed the order, but compliance became an issue because it was very difficult to prove in court because there was no invoice, there was no connection. They clearly said that we are not selling it together. So that was the challenge in proving it. But there were orders from states saying that, look, these products are sold together. If sold together, please take action. But we could not prove it because the pricing, invoice, etc. was coming out. There was no invoice. There was nothing to connect the dots. And therefore, that was a challenge in implementation. Next. So these are certain best practices that I'm reflecting it. This is one way of dealing with the flavoring of chewing tobacco. So what you see is Kenny, which is basically Kenny mixed with comes in a pre-sachet kind of form where it's clearly seen the ingredients is tobacco mixed with lime, water, menthol, oil, spices, etc. Now, lime, water, menthol, oil, spices are all food ingredients. They are food additives. So some states specifically said that the regulation says you cannot mix tobacco with food. Therefore, you cannot have food additives also mixed with tobacco. And therefore, dealing with flavored chewing tobacco, certain orders were passed under regulation 2.4, 2.3.4. And this is one way of dealing it. And this is one of the best practice. You can still, anywhere which you have find flavored chewing tobacco, you can rely upon regulation 2.3.4. Next. This is the sample notification from Bihar, where it explained why food additives are added, how food additives are food product under the Food Safety Act, and how it would come such sale would come under the ban of regulation 2.3.4. So this was one way of notification dealing with flavored chewing tobacco. Flavored and scented is what they use. Next. This is a very comprehensive notification, one of a kind in the country, where health argument are given to ban all kind of smokeless tobacco products. and they are explained. It's not one, it's gutka, chewing tobacco, kharrak, and etc. Everything is mentioned in this mawa. Everything is mentioned. So Maharashtra is the only state that for the last more than a decade, since 2011, I think was the first notification, till 20, they have consistently issued notification to ban all kind of flavored chewing tobacco, and there is enough judgment supporting this ban. Next. This I wanted to highlight because for a reason that this is another way of dealing with twin packet and dealing with pan masala is that pan masala as such standalone has a specific standard mentioned, and one of it's clearly said that magnesium carbonate, which is basically added to increase the shelf life of pan masala, shall not be used. So what state government did was they tested it for two things. Firstly, magnesium carbonate and also nicotine, which is banned to be used in food article. And these are certain examples where most of the tests had, especially Rajnikanta, had both magnesium carbonate and nicotine available. So what did the state government did? Well, after they got the lab test, they banned these brands using the Commissioner of Foods emergency power under Section 30. So this is one another way of dealing with it, that since standards are laid down, test it for adulteration. If you find magnesium carbonate or nicotine, ban the product. Next. So these are certain orders from different states where they have tested the product and they have banned it for having magnesium carbonate and nicotine. So we have in India several labs. I think we have 6 now. We have 3 with 2, I think 5 now, basically, which is purely for testing tobacco products. Make use of those labs. Get it tested for these ingredients. If you find them, uh, use the food commissioner power to ban these brands. Next. So this is one image I wanted to show it from Bihar, which is before the ban. So when pan masala was being sold, it was heavily advertised. There are like it was kind of, you could see it, hanging also there. And once the ban came into effect of SIPHER, because the SIPHER also was on the list, which had these adulteration, magnesium carbonate and nicotine. Once it was banned, then the same shop did not have these advertisement, did not have these sales. So there is an immediate impact. So pan masala is the main thing. If you want to target twin packet, that you should, if you want to target surrogate advertisement, you must look at reaching out to how to regulate pan masala. And these are certain ways, best practices I showed you that can be done. Next. So food safe, since it was treated as food products since independence, food safety is the obviously is the important integral law, but there are other laws also that are normally used for smokeless tobacco. One law is the cigarettes and other tobacco product, which is COTPA, and Section 5, which is on advertisement, direct and indirect ban. Section 6, which is sale near educational institution and to minors, and 7, which is having warning on packet. So this is one law that can be also used for regulating and on smokeless tobacco product. Then there's Juvenile Justice Act, which bans giving to person below the age of 18 years. Giving means for both sale and for use, and the imprisonment is almost 7 years and 1 lakh rupees fine. There is Child and Adolescent Labor Act, which has 3 years or more imprisonment if you give it to a child for manufacturing of tobacco products. There's Environment Protection Act. I specifically wanted to highlight because this rules came under the Supreme Court guidance. It specifically bans packing of pan masala gutka in plastic sachet. I think that's another rules that we have not used. Then you have Drugs and Cosmetic Act, which bans use of tobacco and nicotine in tooth powder and toothpaste. Now there are certain products like gul, which is used as a dental application. Now these are certain products that can be specifically regulated under Drugs and Cosmetic Act. This regulation was passed in 90s. It got the Supreme Court approval also. The ban was upheld in public interest. So these are certain law that you can look into. Consumer Protection Act is recently being used. It came out in 2019, where there is a punishment on endorsers. Means if you see a film star or a sports person, whoever is a celebrity, promoting a product which is generally injurious to health and misleading. So if you feel the pan masala ad is misleading to the consumer about its ill effect because it's injurious to health, it is cancerous, it needs to have 50% warning, you can anybody, any of us sitting here can log into their consumer protection grievance tribunal thing, make a complaint to consumer protection authorities, send images saying this is violation of your your sections, and please act against it. So there are certain cases that have been pending. The Bharatiya Nyaya Sanhita, I'm mentioning it, which is basically a follow-up to the IPC, Indian Penal Code, previously known as Indian Penal Code. There also, there was certain provision which state government of Maharashtra and other have used, like adulteration, like not following public officers' order, like poison, administrating poison, to enforce the gutka and chewing tobacco ban. So this is something, those IPC section are part of BNS also. You can use it here also to enforce the ban. And Poison Act, some states like UT of Chandigarh and Karnataka have declared nicotine as poison. So this is also one act that you can possibly use. So what I would suggest that we may use the food safety law and other law if you want to kind of regulate smokeless tobacco. Yes, next. So as a way forward, I'll suggest that strong enforcement and a change in policy are two ways we can address the smokeless menace. One is obviously states that are working on a ban. I would suggest not to use for gutka ban. Please do not use emergency power of Section 30. Use only regulation, because uh, if you use Section 30 of food safety, you'll have to issue a notification every year. So that is what the ban is there. Please use it. Please also use the current regulation 2.3.4 for acting against chewing tobacco, where food additives are added as scent and flavors. Then work with the enforcement agency to collect samples of pan masala and test it for impurities like nicotine or magnesium carbonate, and go ahead and ban those brands which are found violation. Use the drugs law for where dental application of SLTs are available, because it's a banned item under the Drugs Act. And then use the plastic law, because this is one thing which has not been strictly enforced. That's also a big cost to the industry if you enforce the plastic ban, because otherwise they would use paper or something which is not very conducive to for a shelf life, etc. So plastic. And lastly, for surrogate, which is becoming a main menace, firstly there should be an action under the misleading advertisement under the Consumer Protection Act and other. And also you must, I think, considering the ill effects of pan masala, etc., we must reach out to the policy makers to enforce that there should be a ban on surrogate advertisement of these products. Yes, thank you. Lastly, yes, so I'll end here. Any questions?
Thank you, Ranjitji, for telling us about the legal framework for regulation of facilities in India. You told about the Food Safety Standard Act of India, the 2006 and the 2011, and how we can control the menace of this pan masala and gutka, etc. And you told us about the clause 2.3.4. So twin packs, they are not allowed, and you also shared the good practices of uh, certain state governments and the UTs. So it was an excellent presentation. And the last slide regarding the way forward, what we can do about it, how to ban SLT and how to enforce it forcefully. So you told about it. So thanks a lot. Thank you.
Thank you, sir, for your very comprehensive talk and the legal ways we can stop the smokeless tobacco. Moving on, we are deeply honored to have with us Dr. Jagdish Kaur, who is the regional advisor for the Tobacco Free Initiative at the WHO Southeast Asia region. Ma'am, we are very grateful for your presence today, and I request you to kindly deliver the chief address.
Thank you so much. Thanks so much. And thanks, Dr. Rakesh, for organizing this very important event, because I think smokeless tobacco, we can talk a lot of about this topic. And we heard the experts, from different angles. Dr. Shalini, she presented an example from another region. And we heard Ranjit on the legal perspective. And we had different ways to control, and the perspective what a smokeless tobacco is and what happens. We have spoken again and again, we have spoken repeatedly on smokeless tobacco, but it's still it is there, and it's going to be there for some time, and I think we need to do more. So there are 1.2 billion tobacco users all over the world. Out of that, 359 adult smokeless tobacco users are there globally. And out of that 359 in the Southeast Asia region, there are 288 million smokeless tobacco users. And mainly in India, most of the burden is in India and then in other countries. And in many Southeast Asian countries, it is increasing. And now we have more than 71% of the global burden. So that is a lot. So it's basically the challenge for this region. I mean, India is, a big contributor to that burden. So of course for India, but also to the other countries of the region. India is now implementing the third round of GATS Global Adult Tobacco Survey. They are also having the fifth round of Global Youth Tobacco Survey. So we will know, what actually is the position now, because the last surveys, they were done quite some time back. So we'll have the updated evidence on that. And we heard that, the labs are also there, and the labs are producing that evidence also, because when you are enforcing the law, you always need the updated evidence. So we have 4 laws as part of the National Tobacco Testing Laboratories in India, and they are all part of the WHO Top Lab Net, which is a network of the laboratories. We heard that tobacco, smokeless tobacco, it causes health issues, the economic burden, environmental issues, other issues, it is linked to poverty. And we heard Dr. Lakshmi from Sri Lanka. She has worked for a long time on tobacco and non-communicable diseases. So, how it affects the poverty and overall development, the SDGs, how, that perspective is there, and why we talk of different approaches for the control of tobacco and then smokeless tobacco. So, the Southeast Asia region in the last regional committee meeting, 78th regional committee meeting in 2025, on the request of the countries, the member states, we came up with a regional strategic framework to combat smokeless tobacco, novel nicotine products, and areca nut. Because smokeless tobacco, it's rising in many countries. And at the same time, we have the novel nicotine products. So we are having now, besides the electronic cigarettes, the nicotine pouches, and then areca nut, which is consumed along with the smokeless tobacco, like we heard in detail from Ranjit, how the pan masala now is being sold separately along with these pouches of tobacco. So areca nut is nobody's baby, because the Framework Convention on Tobacco Control, Empower, Best Buys, nobody looks at, from any angle at areca nut. So we came up with this regional strategic framework. Now all the 10 countries in the Southeast Asia region, they will implement this framework, and they will report back to the regional committee, Southeast Asia Regional Committee, in 2027, next year, and in 2030, as per the 14 key performance indicators. So we will know, what is the progress happening in preventing and controlling smokeless tobacco, novel nicotine products, as well as the areca nuts. So this is the first time the region has come up with this framework, where the countries will establish the platforms, if they don't have, for areca nut, or if they have, they will strengthen, and then they report back to us. So I think this is a big step forward. And for the smokeless tobacco specifically, and because areca nut, they go hand in hand, I will say, we need to focus on 3 things. Like we heard India, the laws specific to tobacco, I mean, they are there, but then we have different laws, the food laws, other laws, juvenile law, poison act, the general laws, which can be, implemented and enforced. But I think for these products, we need to have sustained behavior change campaigns. We had a series of youth campaigns. We need to sustain behavior change among the adults as well as the youth, so that they continue to be away from these products. And second is that the enforcement side of the law, we need to look at that. I mean, it's good that, okay, we have COTPA, we have PECA, we have everything, but they are not being enforced because the products are available. And this OTT thing which has now come, this films rules, they are relevant to the these platforms, OTTs. But all the films these days, they are showing smoking scenes, and they have increased so much on I think COVID time and post that. So that is not under control at all. I think that needs to be, because the youngsters are taking over, and there's a study, economic study, which is I think it's under review, and it is coming shortly. And once it comes, it's mind-boggling. What's happening in both rural and urban areas as far as these tobacco products are concerned. So it's really, really, very worrisome. And third is, I think we need whole of society approach. So we have the laws, we have other things, and we need to now have everybody coming together. And this is what we are also advocating in the regional framework which has come, so that everybody comes together, because tobacco affects everything. And I think especially this development argument, it should be part of the overall development plan which the country has. So it has to be a whole of government, whole of society approach, and all partners, stakeholders, they have to come together, and they have to fight this battle. Because otherwise, at the ground level, the situation is really, really very grim. And as tobacco control people, fraternity, we all have to be, taking note of this situation. And we have Dr. Shalini from the hub, and we have the labs, and we keep producing the evidence, from time to time to guide the policies. But then I think the law has been there for long, and in fact, the country is committed to the WHO FCTC, and you have to report every year to Empower also. So I think this needs to be, being looked at in a very integrated uh, manner. And because nicotine, now the new nicotine products are coming, and they are so addictive, and so many harmful, effects are happening. And I spoke at the CAMCON on 1st of March, a day before, and there also, I was requesting the experts that we need to come with the comprehensive integrated approaches now, to look at addiction, because now this is a war against the addiction. So it's not a time that we just look in silos. Siloing, it won't help. So whether it is tobacco, it's alcohol, it is substance, it's nicotine, we have to just focus our approach. We have to, just beat this together, and all kinds of addiction, because industry has really taken over all these things, and they are changing it into, for us, the nicotine addiction. But then there are other things. And then there is some integration from our end, like, based on the success of tobacco tax, now we are talking of health taxes, so we include alcohol and the sugar sweetened beverages also. So same way, I think we need to have comprehensive approaches, learning from best practices, what we have successfully done, and how we can look at the challenges, and how we can take over those challenges in the best possible way. So these are the few my thoughts, I wanted to share with you. And thanks for the good work you all are doing, and continue to do so. And all of us have to work together. Thank you so much.
Thanks a lot, Dr. Jagdish, for summarizing the whole consultation. And you also told about the global burden of SLTs, the upcoming GATS 3 and GYTS 5. They are surely important. And you also told about the new emerging nicotine tobacco products like e-cigarettes, oral nicotine pouches, areca nut, SLTs. They are also new emerging actually products. And you also told that what we need to focus on to enforce the laws which are already existing against the SLTs, the behavioral changes required for the youth, then the whole of society approach is important. And thanks a lot. Thanks for sparing time for us. Thank you.
Thank you, ma'am, for giving the presentation. And thank you to all our speakers for your insightful presentations and your remarks. We now open the floor for questions. The participants are requested to either unmute themselves or write their questions in the chat box.
First of all, I'll ask Mr. Ranjit Singh that why state governments are issuing notifications under Section 2.3.4 just for 1 year when we can do it for once and for all. Because some of the states, they have done it. Yes, Ranjit?
Sorry. Yeah.
Okay, yeah.
I think that's because there is a legal confusion regarding because states are not sure whether they have that power to ban it, and that's despite the Supreme Court clarification. So the states like Manipur or some states which have issued notification in the beginning in 2013 simply under 2.3.4, they are not issuing notification every year. But some states who have used the emergency power of Section 30, which is only limited for 1 year, they keep on repeating it because otherwise it lapses. So that is something we've been saying in the national consultation recommendation also. It's come out in several, our recommendation representation that if because the law is there, you don't need to even issue a notification. So these are basically an enforcement order. So you just issue it saying for compliance to 2.3.4. I think at that time when we were analyzing it, Chandigarh was the best example. It had a 3-line order saying to all food safety officer to enforce the ban on gutka and pan masala with tobacco and nicotine under 2.3.4. And that is all you need. You don't need some lengthy notification for at least these two products, which is clarified by Supreme Court that it is a ban under this regulation. So the challenge is when you start using Section 30, which is a food commissioner power, which is limited to 1 year. So,
yeah, but most of the notifications are under 2.3.4. I think you need to get issued a clarification regarding it from the Ministry of Health and Family Welfare. So
it did. I think that both food safety and ministry issued a clarification. They sent it that use this. Nobody said use Section 30. Wherever they've used 2.3.4 along with Section 30, that's why they're issuing the notification again and again. But states that have only issued under 2.3.4, they are not issuing notification from that from time to time. So that is the only difference that is erupting for products. But then there are other smokeless also, like the states have gone ahead and banned chewing tobacco products, and there they have been using the emergency power. Then states that have banned pan masala separately after lab tests, there they have been using emergency power. But for gutka and pan masala with tobacco and nicotine, the notification should only be under 2.3.4.
Okay. Thank you. Thanks a lot.
Thank you, sir. So there was a question by Dr. Zili early on. He had asked that initiation of smokeless tobacco, is it different from smoking? As you said, the initiation starts at 18 onwards. The question is open to all the panelists if anybody would like to answer.
Dr. Lakshmi, can you answer the query?
Yeah, I can answer, but it was not came from my presentation. But I know, yeah, it is different. I think she said about smoking, but not SLT. SLT started very much earlier. Although mean age came as 13, sometimes in rural communities, women in Asia, they start as early as 9. But in published research, you get 11 years as the early one. So much earlier than tobacco, other smoking.
Yeah. Thank you. Thank you.
Thank you. There's one more question uh, by Dr. Raghunandan. Is there any particular age when the cancer will be attacked easily?
Dr. Shalini,
Rather,
she-
he means a person who starts smoking, and at what time will the cancer attack the person?
No, it's a multifactorial occurrence, you know. It depends on both the, as we say, seed and the soil. And the seed is the cancer and the soil is our metabolic environment. And smoking or use of addictive substances, or, you know, I should say these poisons, so-called. So their duration, their frequency, their kind of carcinogens it contains. So it all varies. So you can't say really when it is going to come, but certainly it's going to come because you know, some people start very early. They have accumulated that damage in their genome. That's when mutations happen and cancer occurs. So there is no prescribed age limit or where we can say, you know, then it's going to appear. No, but we can say that the median ages of having cancer is this and that. So it varies from geographies and with type of product use and so on and so forth. I hope I'm able to answer.
Yeah.
Sam, is there any other question from the participants? You can unmute yourself. We've had very interesting presentations.
Or we can have even concluding remarks from Dr. Dilip, Dr. Siddhi, Ms. Susan, Dr. Rana, whoever is present here. Just one concluding remark. Yes, Dr. Siddhi, do you want to say anything?
Yes, sir.
Yeah.
Sir, yeah, definitely. This was very important and very nicely presented session. I am here in Gujarat, Jamnagar. Here we see, I am in public health. So what we see here is they'll be using MAVA and myth, as ma'am had many times stated, about there is a myth that Supari is okay, culturally acceptable. But we in public health, we keep telling everyone here because OSMF is widely present. So, smokeless tobacco and supari, both. Cigarette smoking and so this thing will not be here much. Alcohol is so not there only. But the supari is widely used. So, that is very important, and we need to make this more known to people that smokeless tobacco is more and more harmful.
Yeah. Thank you. Thank you.
Thank you, ma'am.
So, Dr. Paridhi, if there are no queries, then you can just proceed with the formal vote of thanks. Yeah.
Yes, sir. So again, once again, thank you to all our panelists for giving wonderful presentations and for your remarks. It's my pleasure to give the vote of thanks. So on behalf of SIPHER, the degree section at the Union and ECHO India, I extend my sincere gratitude to Ms. Upinder Singh for giving the overview, Dr. Shalini Singh for giving the keynote address, Dr. Lakshmi for highlighting the socio-economic dimensions, Mr. Ranjit Singh for clarifying the legal framework, and Dr. Jagdish Kaur for her leadership and regional guidance, and to Dr. Rakesh Gupta for chairing the entire session. And thank you to all our wonderful participants for your attention and for your engagement during this very important consultation. Thank you, everyone, for joining in today. Discussions like today strengthen the collective resolve and advance to meaningful tobacco control action across Southeast Asia. So, thank you for joining in. Have a good afternoon. Thank you.
Yeah, thank you all. Thank you. Thank you. Thank you.
I'll be sharing the feedback link in the chat box. I would request if you can just take a minute to share your feedback.
Thank you.
Thank you. Sir, I'm closing the session.
Yeah, yes, you can close the session.
Yeah.